Hemolytic Uremic Syndrome, or HUS in short. Let's begin with features. Pathophysiology of HUS. Due to abnormal endothelial function of the kidney blood vessels, there occurs tendency of thrombosis leading to platelet activation and the attachment to the thrombi. This activity may occur at massive scale, leading to consumption of platelets in large amount, hence causing thrombocytopenia. These platelets, along with thrombi, narrows the blood vessels. Moreover, the surface of platelets act like a sword to the RBCs flowing through this narrow channel, hence resulting in breakdown. Excess breakdown of RBC inside the vessels leads to microangiopathic hemolytic anemia. The narrowing of renal vessels along with the breakdown of RBC together causes decrease in the blood supply to renal tissue, resulting in renal dysfunction. All these three features can be seen in HUS triad. Now let's come to the types of HUS. There are two types of HUS, that is D positive HUS or typical HUS and D negative HUS or atypical HUS. D positive HUS is precipitated by dysentery like illness. Here the D stands for dysentery only, and the most common cause being E. coli O157H7 and the Shigella. D negative HUS is precipitated by OCPs or hormonal agents and is associated with the causes like CT disorders, that is connective tissue disorders like SLE, scleroderma, or alternate complement pathway defect. Now let's see the clinical features of HUS. As we have already studied the HUS triad, it is easy to determine the clinical outcomes. Since anemia, we see pallor with or without icterus. Since abnormal vessel function and thrombocytopenia, we see petechiae and purpura along with mucosal bleeds. Since renal dysfunction, we can see acute nephrotic. Let's move ahead and see the investigations. Investigation can be broadly based on hemolysis and AKI features. Based on the hemolysis, we can investigate the levels of hemoglobin and the platelets which are found to be decreased, serum LDH and serum bilirubin which are found to be increased. Based on AKI features, BUN or blood urea nitrogen is found to be increased along with increased serum level of creatinine, potassium and phosphate. Another investigation related with hemolysis can be done is PBF or peripheral blood film. It shows schistocytes, spherocytes and or Burr cells. Finally, let's come to the treatment. Since the disease is mostly self-limiting, hence we give supportive treatment, but in severe cases plasmapheresis and FFP, fresh frozen plasma, may be used. Monoclonal antibodies like eculizumab, which decreases the alternate complement pathway activation, is also helpful. Also, one should consider treating underlying cause or withdrawing the precipitating factors. Immunosuppressive therapy may be required if associated with connective tissue disorders. Child HUS versus adult HUS. With respect to TTP, let's see it. More than 90% children develop CNS issues with HUS, but adults develop it less often. Hence, in a child HUS is equal to the TTP only. But in adults, if the HUS is given with CNS features with fever, then we call it as a TTP.